So now I want to speak about how to perform ultrasound guided injections, especially applying the knowledge to know how to make the injection procedures in the musculoskeletal system, and also to become familiar with tips and tricks in this type of procedures. As we know, diagnosis and injections and interventionismus has different learning curves, but both are very dependent on the operator. Interventionism are invasive procedures controlled by ultrasound. The most frequent of them are injections, including nerve blocks, and also punctures, including biopsies. Last time, ultrasound helped us also in surgery, especially in percutaneous surgery with little incisions, just with alternating ultrasound and surgery, so known as sono-assisted surgery, and also in the last years by instrumentation control that exclusively is controlled by ultrasound and sonosurgery. The advantages of sonointerventionism are well known. There are no radiation. The security to reach the target is higher. This is a real trust for the physician and also for the patient. We can avoid or minimize the pain during the treatment. The tolerance is bigger, and in some procedures the results are clearly better. The most important is just that the technique has to reach the joint recesses when we inject intraarticular. We have to know the real anatomy of the recesses, and the real target of the invasive interventionism is just to reach these recesses even with little effusions. To perform an invasive procedure, the following is generally required. We need ultrasound with a linear probe. We have to obtain always an informed consent. Before we make the ultrasound, the diagnosis or the procedure, we have to make a pre-examination of the area just to decide whether or not to perform the procedure, to identify the objective and its environment, to find the most suitable acoustic window, as well as the path of the instrument to avoid the relevant structures, and also to choose the shortest path to the objective and to select the most suitable position for the patient and the doctor. This is very important because we have to maintain in a line the monitor, the injection, and the view of the operator, just to have all in a line like a hunter will make when he goes to hunt. This is real planification. We have to plan first and then to act and to make our injection. The technique is facilitated with fenestrated cloths just to reduce the risk of infection. We need sterile gloves and the technique not touch. In discussion, always the use or not to use sleeves or covers for the probe. We don't use it very often. We use generally alcohol solutions just to make our disinfection of the skin and also for the probe. And in case of surgery, in cases of sonosurgery, we prefer to sterilize the entire probe, just to use the probe as another instrument like otoscope or another instruments. Indications for interventionism are many, in the last years always more. the anesthesia, regional or truncal, the drainage of collections, autocentesis, biopsies, treatments of tendinopathies, neuromas, barbotages in tendon deposits, soft tissue treatment like injection of hyaluronic acid, pulse and joints injections, access of vascular, ultrasound-guided surgery, and also extractions of foreign bodies. Important is just to choose the correct needle, just to go in the depth and also in controlling the entry point. We have a lot of needles, so we use normally needles that goes from 16 to 25 gauge and lengths from 2 till 7 or maximum 10 centimeters. The most used are both the 20 gauge, the 7 centimeters for the shoulder and for the hip, and normally for all other options, the 21 gauge and 4 centimeters length. As we see when we speak about needles, when we make aspiration, ganglions, hematoma, we use normally thicker needles between 16 and 21 when we make our injections between 21 and 27. Syringes almost always using the lunar lock connection. When we make injections, the general most important consideration is just to control the width and the length of the needle. That has to depend, really depend on the deep and the condition of the target. Most of the procedures can be done ambulant, and the two most important considerations is just to control the entry point and to mark also the entry point when we make our planification, and to control the deepness of the target. As we see, we can mark the implant injection point here in Bianchi's book, how he does it. Just with a graphic marker, we choose normally better pressure mark just to avoid this graphic mark on the skin. We always used very often also the trick just to put a needle between the transducer and the skin, just to mark the middle, like here in the AC joint, the middle of our target, and then with the mark of the needle, just putting a pressure mark just on the entry point. As we see here, making infiltration of the easy joint just with the marker on the middle of the articulation of the joint, just going then perpendicular on this entry point. Also important just to control the deep, like here we have to control that if you want to make an infiltration of the sciatic nerve underneath of the piriformis, we have to check that the target is 3 centimeters. When we go in an oblique position, we have we need a longer needle just to go in that depth. There are two techniques just to make our infiltration. The indirect technique. In the indirect technique, the ultrasound is only used to mark the injection zone and also the depth of the target. When we have controlled the depth and the position of our infiltration of our joint, we mark it, and then we go without ultrasound guidance direct into a joint. We see here how we have marked the third and the fourth compartment on the wrist, and just between both compartments we know that in 2 centimeters deepness is the joint. We go perpendicular, and so we try to find the joint without direct control. This is a solution that we use very often just in cases for pre-operative planifications. We see here a fracture. We can mark the length of our fracture. We can mark also the radialis nerve, and then we can plan on the skin our intervention, our operation. Another case, just in case of Achilles tendon rupture, we have marked the rupture, we have marked the suralis, and we mark also over the rupture, just the point of entry of our percutaneous suture. As we see, we can plan the operation on the skin with the use of ultrasound in the planification. But mostly we use the ultrasound just to control the instruments and the needle just in the direct technique. Two modalities also, the lateral approach, in which the instrument is introduced parallel to the long axis, and we will visualize the entire length of the needle in this case. This is important just to control, because we have to be quite perfect on the line. When we are perfect on the line, the sound beam goes through the needle and we will see the whole needle. The only problem on this approach is if you move a little bit and the transducer is not very parallel to the needle, we move a little bit the transducer, we won't see anything of the needle. This is why the anesthesiologists speak about the approach in plane. On the other side, the coaxial approach is a perpendicular approach. The instrument is inserted perpendicular to the long axis, and we will here see only a partial visualization of the instrument. We go through the sound beam and we see a point, a lightning with reverberation in the deep. The only problem is in all oblique positions of the needle, we will see the same lightning point just in the central when the needle goes through the sound beam, but the bevel could be on different places. This is why the anesthesists speak about the approach out of plane. Which approach is better? What would we said? What would we considered? Most important is just to see this image. If we see the needle is in this preparation model, just going inside a vessel. We see that the needle has just passed the vessel, is inside the vessel. But if we control it on the perpendicular, on the coaxial approach, we see that the needle is just very, very close to the border of the vessel. It's not directly in the center, it's just directly lying on the very lateral, just targeting only the periphery of the vessel. If we want to be sure that we are on the center of the target, we have to combine always the two axes. This is easy made by the ultrasound, just only moving 90 degrees, rotating 90 degrees the probe. We can see here in these examples, we are here inside the patellar tendon, just in the undersurface of the patellar tendon. We are real in the place of the tendinopathy, but we don't see if we are on the proximal or the distal. We have to rotate the transducer just to be sure that we are on the proximal part of the patellar tendon. This is the same in this hiatus sacralis injection. We want to know if we are in the middle, we are going through the ligament inside the hiatus, but if we want to know if we are very centered, we have to control between two cones that the needle in both axes are correct. Also in this infiltration of the plantar fascia, we see here that we are on the middle of the fascia, but if we want to see if we are proximal or just a little bit distal, we have to move and to rotate our our transducer just to know that we are on the correct place. So we how we do it? Um, we speak about tricks just to control the needle, to have the needle always in our view. We speak about 8 tricks just to perform the guided injection. The first one and the most important is this, that the needle has to be so parallel as possible to the transducer. This will improve the visualization of the needle, just correct. Because if we go very parallel with the needle to the transducer, all the sound will reboot direct to the transducer, and we will see the needle perfect. Doesn't matter if the needle is very thin or thicker, we will see the whole needle just perfect on place. But if we go a little bit oblique, we see here in 20 degrees or in 40 degrees, obliquity, the needle, the same needle as this one, is not so well seen here in this direction, and is not very easy just to control with an obliquity of more than 45 degrees. So this example, a very thin needle, 25 gauge needle in a tibio-peroneal syndesmosis injection. We see the whole needle with the reverberation just only because of the parallelity of the needle and the transducer. The second trip is just to avoid the oblique approach. How can we recognize it? Oblique approach only cut a little of the needle, not the biggest of the whole needle. We see only one part of the entire needle, and we don't see parts of needle that are going oblique through the beam. Important is just when we see the whole needle and also the bevel, we are direct on the parallelity of the whole needle. We have always to try to get the needle and to control the bevel, avoiding this oblique approach. Do not enter if the tip is not visible, and mind always the tip of the needle. The third tip, just to try to get the needle so parallel as possible. In many ways, in many places, this is not possible, like in the hip. We have a solution, a software solution of the ultrasound is just the steer function. We can rotate a little bit the beam, making it oblique, like here, so about 20 degrees, with the steer function. If we put the steer function on, we see the same needle, just with a bigger reverberance, just because of the obliquity just of the case of the box of the beam. Another example, the same needle, just without steer and with steer. You see the same needle, the same position, the reverberation in this case is quite bigger than in the first one. An example in the hip with a almost 30 degrees steer function on, we can see mostly of the needle just going in a case of a labral cyst injection over the femoral head. The fourth tip or trick is just to take advantage of the convex areas. It helps very much, these technical tips. Avoiding going too close to the transducer and taking advantage of the convex areas. If we go a little bit away, trying to get a more parallel position of the needle just to the transducer, we will improve the visualization of the needle. Not too close to the transducer, taking advantage of these convex places going 2-3 centimeters from the probe, just to try to get the needle so parallel as possible. Some cases this is impossible because we have a flat surface. In these cases, avoiding to go too close to the transducer and making a little bit flat the angle going 3-4 centimeters from the probe, just make better the visualization of the needle. The only problem is we have to choose a longer needle, and we have always to control the blind space between the entry point of the needle and the border of the transducer. We have to control it and to control the place before we make our infiltration, just to see what happens here in this plane space. We see the needle in this 30 degrees. We see very good the needle in such an angle. The sixth trip is just to, in this flat position, we can also just to gain a little parallelity, to skew the transducer, pushing or making pressure just to the skin, to the subcutaneous tissue, just to gain parallelity between the transducer and the needle. We can also try to make it putting a very big layer of gel. The only problem is that this remains only a few seconds, and the stability and the asepsy of the solution is not so well. We prefer to make to skew the transducer just to make our pressure on the skin. Another trip is just to take advantage to the movements of the needle, to rotate, or just to move the needle. We are here infiltrating injection the piriformis syndrome just over the sciatic nerve, and just to control where the needle is, we can move a little bit the needle, or rotate the needle just to control with movement the needle. And the last one of the most important, is just in special places, because of the price of the needle is quite greater. It's much more expensive. Just to use the rifle needles of some devices that we can use, like here. We see the rifle part of the needle is quite better seen as the flat part of the needle. This solution is quite better, very good when we infiltrate in very close to the nerves, or just in some difficult position. We can use this type of needles that we will see better. In conclusion, ultrasound has demonstrated to be a very useful tool to guide infiltration or function in the musculoskeletal systems. It is essential to combine anatomical and ultrasound knowledge just to develop the technique. We prefer a freehand and a direct technique to reach the target, but always reminding to take advantage of both axes. We have to move the transducer just to see that we are on the center of the target. And prior to the procedure, it's obligate to study the best path to reach the target. We have to plan, we have to make a planification of the target before we make the infiltration, not just when the needle is inside our objective. So I thank you very much.